Thank you, Olga. I'm very happy to be with you today. Thanks for the invitation. And my relation, can you hear me well, yeah?
Da. Yes, we can.
My relationship with Russia is particularly strong because I have been there for a few times. I've seen how hard you are working to improve the quality of the management of children with SMA. And also, I have had the opportunity to work with some of your families coming to when I was working in Italy for clinical trials. So really there was a strong contribution from your country to implement the success of these new treatments that are becoming progressively available. I just wanted to briefly mention about the difference of types. So I will talk you today about the importance to implement the standard of care. We now have some available treatments, some therapeutic options. Also, I know that also you have nusinersen in Russia. You have some access to risdiplam. You will probably have access also to gene therapy in the future. So, but it's still very important to understand how to better manage this disease, because unfortunately, even if you mention that, yes, it is now a treatable disease, it is even probably more important to understand how we can prevent the possible complications. We still need to be very alert to manage all the different complications of the disease, because unfortunately, this is a treatment, it's not a cure, and these children can still have some of these issues. So you know that, these are the three more common forms in childhood: the type 1, which is the most severe; the type 2, which is intermediate, so the children are able to sit, while the type 1 are never able to sit; and the more milder type 3, where children are able to walk, and some of them can also lose this ability over time. But you really need to consider these three forms as a continuum. So there is not a very straight division among the three types, but it's like a continuum. So we can have like a stronger type 1 who can be quite close to a type 2, and vice versa, some type 2 which could be very weak and have some of the complications, for instance, the respiratory complication, the failure to thrive, and so on, that are more typical of the type 1 SMA. So this is a typical type 1 SMA, and these are the key features that we need to consider in order to understand how we need to implement the multidisciplinary management of this disease. So you know that there is this severe weakness, this severe hypotonia, which mainly affect the trunk and the limbs. Orobulbar dysfunction with difficulties in swallowing, difficulties in feedings can be a major issues, with, of course, all the implication with the failure to thrive for these kids, and the need, as we will see, to implement nutrition. Respiratory complication can be a major issue, and also quite often the cause of death in these kids very soon, by the age of 2 years. They have very poor and very weak intercostal muscle, so their cuff is very weak. They can have difficulties in clearing their airways, so they can have recurrent chest infections. And as you can see from this picture, they have a typical bell shape of the chest, because the intercostal muscles of the upper part of the chest is less functional, weaker, while the diaphragm is a major muscle who is working for maintaining their respiratory efficiency. The type 2 are able to sit, as you know, without support sometimes. Some of them can lose the ability to sit over time with the progression of the disease. They can have different complications because they can develop severe contractures, especially in the limbs, so in the knees, in the ankles. They can develop severe scoliosis. They can develop over time also respiratory complications, and some of them can also die later on for this respiratory complication if this is not properly managed. On the undernutrition, so underweight can also be an issue for them because with time they can develop bulbar dysfunction as well. You can see here from this picture the severe scoliosis that progressively happen in these kids, and also the other complications that I mentioned, like respiratory failure and recurrent chest infections. The type 3 have a more stable course of the disease, but they can develop some other complications over time. Some of them can lose the ability to walk, especially after 10, 20 years of age. They can develop scoliosis, they can develop contractures, they can develop some respiratory failure with time, but they have usually normal life expectancy. So one effort that has been done in the past, before the advent of the current medication, was to try to find a way to address all these different aspects and complications of the disease. And there had been a shared agreement with the experts worldwide, so that this revised recommendation have been published a couple of years ago to address properly all these aspects. One aspect that I would like to highlight, first of all, now that there are some available treatments, is the early diagnosis. I know that because I've been in Russia, so I've seen many of your patients, and I'm aware that Russian doctors are particularly good at capture SMA very early. So usually we have diagnosis very early. And this is very, very important because we know that the earlier we start a treatment or the management of disease, the better will be the outcome of these patients. So the suggestion is, the advice is, as soon as you realize that there could be the suspects of a possible SMA, just refer the patient to the neurologist, to the pediatric neurologist and the geneticist to make the genetic confirmation. Because of course, especially for a type 1 SMA, it will be important to start the treatment very soon. This is a diagram showing how important is the multidisciplinary management of these patients. We consider that the family and the patient are in the center, and usually there is one coordinator of all the different aspects, which could be a nurse, which could be a doctor, which basically is responsible for liaising with and organizing all the different professionals to take care of the children. I want to start with the pulmonary management because this is very important. Even if we are treating patients, respiratory complication should not be underestimated and should be properly addressed since the early diagnosis, since the start of diagnosis. This is very important because sometimes we see patients improving in motor function, but they can show abrupt onset of respiratory complication, which require proper management. So I've mentioned that they have poor cough, and this results of poor clearance of the airways. They have bulbar dysfunction, so this also leads to increased secretion, so they require frequent suction. I'm talking especially of the type 1 SMA. They can have chest well and lung underdevelopment. They can have hypoventilation at night because we know that at night the respiratory muscles become less active. So it's very important to be sure that they do not show desaturation, so reduction of the oxygen in the blood during the night, because this can further increase the respiratory burden. And the poor cough, the poor airway clearance can lead to recurrent chest infection and esophageal infection. So it's very important to monitor closely for all the types, but I would say particularly for type 1 and the weakest type 2, it's very important to monitor respiratory function over time. It's very important that you look at the child, you look if there is an increase in the respiratory workload. You should look at the chest if there is a progression, a worsening of the chest shape. It's very important that you monitor the oxygen and the CO2 in the blood, because you can have also normal saturation or oxygen saturation, but increased CO2. So it's very important also because in most of cases, these children do not require oxygen, because otherwise, if they have high CO2, by giving oxygen, this can worsen their clinical picture, of course. It's important to regularly a sleep study. We used to do it at least once a year, and even twice a year, if this, and even more frequently, if this is indicated, if you are seeing that there is a worsening of the respiratory function over time. And starting from the age of 5-6 years, we used to monitor in the type 2 SMA the lung function through the spirometry test, which give you several numbers like the FCC and the PCF, so the strength of the respiratory muscles. And you can also look at other signs. You can ask the family, you can ask the child if there are signs of nocturnal hypoventilation, if the child is particularly tired or sleepy, if the child has got diurnal headaches, if there is any failure to thrive or weight loss, which could also be an alarm to think of respiratory complications, if there are recurrent respiratory infections during the winter, during the year. So what to do? Now we have a few equipments, and I have seen that also in Russia, some of these equipments are provided to the families, to the patients. It's important, for instance, to have the suctioning machine to maintain the mouth free from secretion. It's important to do physiotherapy manual chest to facilitate, especially the cough mechanism. It's important to provide, wherever this is possible, an inexsufflator, so a cough assist machine, which can strengthen their ability to cough and to clear the airway. And also, it's important to provide non-invasive ventilation as soon as this becomes required. We try to be very proactive. We try to think in advance when the child will need ventilation. We don't want to provide an urgent tracheostomy to a child if we can foresee, if we can anticipate that child's respiratory function is deteriorating, because the quality of life of a child on non-invasive ventilation and of the family is, of course, much higher. Mucolytics treatment should not be used for these patients for longer periods. And this is a sort of diagram. This is what is considered suggested to do when we see a progressive deterioration of the respiratory function. You can see that initially the respiratory disorders mainly happen during the REM phase of the sleep, but progressively these also involve the non-REM phase of the sleep and also daytime, with progressive deterioration of FVC, of the lung function. So this is when you start to, you need to start to be very alert and very proactive in handling this respiratory complication and providing the child the required equipment, the cough assist, the suctioning machine, and particularly the non-invasive ventilation. You need to be one step in advance before this complication, because otherwise it could be too late. It's very important to have an anticipatory care plan for these patients. As soon as we diagnose a patient and we discharge him or her from the hospital, it's very important that you liaise with the local hospital, with the local doctors, because should this child have an emergency, they should need to be immediately referred to the emergency department. We used to provide antibiotics even at the first signs of a respiratory infection, even if it is at the beginning a viral infection. When we see that there is cough, secretion, increased secretion, that there is fever, we treat with antibiotics, because otherwise the formation of the atelectasis and the plug in the lungs can become a more important problem. Nutrition is also very, very important in these children, because we know that they need energy. They need energy to move. They need energy to afford their respiratory complication and respiratory infections when they are unwell. So bulbar dysfunction and difficulties in swallowing can still be a problem, even if they have a treatment, even if they improve in terms of their motor abilities, and even if they acquire new motor abilities. So it's very important, for instance, to perform, if you have the possibility, a video fluoroscopy to see if their swallowing is safe, or you should monitor how this child is fed. If this child has got weak suction, if he or she gets fatigued when he or she eats and when he is fed, you should monitor the weight and height over time, and I will show you how we do that. And also it's important to monitor the bone health. We know that SMA patients are particularly at risk of bone fragility and osteoporosis. So we recommend to implement vitamin D intake, especially during the winter. And I know that also in Russia, this could be a major issue, because the sunlight can miss several months during the year. So it's very important to supplement with vitamin D. And we used to perform a DEXA scan to monitor their bone health. How we monitor their weight? Unfortunately, so far there are no available growth charts specific for SMA patients. We are working on that, on developing them, so we hope that this will be available in the future. But for now, we use the growth chart for the healthy children. So it's very important to see if the child is following his or her percentile and does not drop excessively from that percentile, because this means that he's experiencing severe underweight, severe undernutrition. But can also happen the opposite, that this child, especially the strongest type 2 on the ambulant type 3, it may happen that they increase too much their weight. And this, of course, can also be a side effect, something that we don't want to see, because, of course, this can affect negatively their motor abilities, their motor and respiratory function. When there is severe underweight, when we see that their swallowing ability is not safe, when we see that even if we increase the caloric intake, even if we try to use the nasogastric tube, but this is not enough, or this child requires the nasogastric feeding for longer periods, a gastrostomy option can be discussed with the family and could be suggested. addressed, because usually this can improve the quality of life of also the family, of course. The degree of respiratory impairment should also be considered. These children can also have gastrointestinal issues like gastroesophageal reflux, constipation, and delayed gastric emptying, and all these aspects can be properly addressed with proper medications. Another thing that we try to do, is to monitor their hydration. So it's very important to maintain their hydration, but also, especially for the type 1 who are receiving some treatment, we try to maintain some swallowing abilities. So some of these kids try to take some oral feeding, even if they are predominantly fed by nasogastric tube or by the PEG, because this function can still be somehow stimulated. I've mentioned that there should be a careful referral for the acute care of this child if the child become unwell. And it's very important because especially the type 1 and the weakest type 2 cannot afford prolonged fasting. So it's very important to monitor episodes of hypoglycemia, especially when they have fever or respiratory infections. Feedings problems can also be observed in the type 2, especially the weakest ones. We have seen that the type 2 with time develop difficulties in opening their mouth. And of course, if they are less able to open their mouth, this can be an issue with chewing and with the oral management of the food. Some of them get fatigued very easily when they eat their meals, because we know that fatigability is a major issue in the SMA patients due to the contemporary presence of neuromuscular junction defects in these patients. It's very important to observe the sitting and the posture when they eat, and some of them can have some transient difficulties, for instance, when they receive the spinal surgery, because of course they lose the compensatory mechanism that they use to swallow the food. So this is really important to discuss with the patient and with the family. That may happen, of course. Rehabilitation is a very important issue. We are seeing a lot of children. I saw, honestly, also in Russia, many children receiving intensive rehabilitation, but intensive does not mean necessarily that it is well focused on the disease and on the issue of the disease. So it's very important to understand what is really feasible and useful for these patients. Joint contractures can become a major issue. We are seeing, Olga was also mentioning about the changing phenotypes. We are seeing that the children receiving the new treatments are changing. They are becoming stronger, but sometimes the fact that they become stronger can be associated with the onset of some contractures in some of the sites where we were not used to see these contractures. We are seeing, for instance, type 1 patients who are developing contractures in the hips because they have very strong movements in their legs. But of course, if they have the hip contractures, they are not able to be put in the standing position because the hip are tight, you know. The same for the knees, the same for the ankles. So it's really important that you keep an eye on the progressive change of the tightness of the joint, because otherwise it will be too late and it will be necessary to intervene whenever possible with surgery. It's very important to provide the right posturing, it's very important to look at chest deformities and to prevent scoliosis. So this is what we usually provide to the children. So you have spinal brace to try to somehow limit the progression of the scoliosis, even if sometimes this is not easy to do. What we are also seeing is that when the children become stronger with the treatment, they can develop even worse scoliosis, even worse progression of the scoliosis, because they can become stronger on one side. And of course, this can worsen the asymmetry and the progress of the scoliosis. So this is very important. This is why it's very important to monitor closely also the orthopedic complication. We suggest to do regular exercises, like regular stretching exercise of the different joints, especially in the lower limbs, so the hips, the knees, and the ankles. But some of them are also developing contractures in the upper limb. For instance, limitation in the movements of the wrist or of the elbows. So it's important also to monitor this. And I would say that with the increase of the treated patients, it's also important, as long as they develop new abilities and new strength, to promote function. So to promote active movement, which can be done in the children using play. You know, you can see from this picture how the physiotherapists can stimulate, you know, the movement of the arms, just, you know, proposing some toys on the top of the head, so that the child can reach these toys and can be stimulated to move their upper extremities, or can be stimulated in standing, for instance, with long splints in the lower limbs to try to promote standing position. This is a type 1 child receiving treatment. So it's very important to propose new active activities to maintain their engagement in new acquisition of motor abilities. These are some of the recommended activities. I know that it's not always easy in Russia to do this kind of activities, but for instance, some of these kids can attend a swimming pool, can go to hippotherapy, or also can do wheelchair sports, and which especially the teenager children enjoy so much. We used to provide manual wheelchairs, light manual wheelchairs, or even power wheelchair whenever possible. So children from the age of 2.5 years can be trained to drive a power wheelchair, to promote development, to promote interaction, to promote independence and relationship with their peers. I mentioned that scoliosis can be an issue. This is how we usually monitor the progression of the scoliosis. So basically, when the scoliosis, the thoracic and lumbar scoliosis is over 15-20 degrees, we provide bracing, so spinal bracing, and we monitor the progression of the curve. But as soon as we go over 50 degrees, we could discuss potential surgery, which could be depending on the age, with growing growths or with the permanent fusion. So this is my last slide. This is the very encouraging pipeline of the new treatments that you can see the blue arrows, the blue lines, where we have 3 available treatments. So we have the nusinersen, we have Visdica, we have the gene therapy, which all the 3 have been approved in the US. Some of them are already available to patients worldwide. Some others will become shortly available. You can see that a number of other drugs are under development, but it is important, this is crucial, to follow and update the standard of care. because the children are changing, their phenotype are changing. And of course, if we want to maximize the therapeutic effects of this treatment, we should be really look at these evolving phenotypes and try to be always one step in advance to counteract and fight all these complications that I mentioned earlier. Thank you for your attention.
Да, спасибо большое, Джованни. Я уже в эфире? Уже. Да, спасибо большое, Джованни. Спасибо большое за прекрасную презентацию. У нас сейчас есть несколько вопросов от слушателей, и для тех, кто еще не успел задать свои вопросы, но они у вас есть, то вы их можете адресовать в чате, который называется «Стандарты», и я все их передам Джованни. Первый вопрос. У неходячих детей нормы веса оцениваются по тем же таблицам, что и у здоровых, или есть специальные таблицы для детей со...
So it's related to the growth chart that we use, yeah, Olga, for the growth chart that we use, yeah. At the moment, unfortunately, we don't have the growth charts specific for SMA children at the moment, and we use the growth chart for the typically for the normal children, for the typically developing children. So based on the age and the sex, there are specific growth charts for all, the ambulant and non-ambulant. With my Italian colleagues and here in the UK, we are trying to develop some growth charts which could be specific for the SMA patients, especially for the type 1 and the type 2 at the moment. These are at a more advantaged phase. And I hope that this will become available in the near future, hopefully in a few months, so that they can be implemented also in other countries.
Спасибо большое. Еще один вопрос, который... Как быть с мышечными судорогами у взрослых?
Yeah, this is a very difficult question. We used to discuss this with the physiotherapists. When there is an issue about this, we try to find the support of our physiotherapists to provide specific exercise based on the site where the cramps are located. Activity, for sure, inactivity is the worst enemy. The more you do, the better it is also for the cramps and the muscle pain. If you have the possibility to do exercise in warm water, this could be particularly helpful. Massage are sometimes also helpful. Some supplements like magnesium can be provided as well, because this can help the muscles to be more relaxed. So all the combination of these activities can be helpful for the patients to fight cramps.
Спасибо большое. И у нас есть еще один вопрос, и тоже про взрослых. Эффективны ли физические упражнения для взрослых с астмой?
Yeah, we always suggest to make some sort of activity and exercise. Stretching exercises are important to maintain the joint motility because we know that, you know, it's very difficult to intervene when there is a tight joint contracture. Active exercise is very important. So to maintain some sort of activity, all our kids, or our children, but also adults, try to do some sort of regular activity. Again, this could be, I know that it's not always easy, but this can also be done on the wheelchair. There are some sports activities. There are some activities in the pool, some activities on the, you know, on the mattress in a gym, some mobilizations. Depending on the strength that you have, you can do some active activities like changing your posture. All this kind of exercise should be regularly done, because we know that, you know, to counteract muscle atrophy is very important to maintain the residual muscle strength and activity for the patient.
Да, спасибо большое. И хотела сказать, что в воскресенье у нас будет в гостях Меган Мейн, физический терапевт. И я думаю, что еще много чего интересного она расскажет как по отношению физической терапии у детей, так и у взрослых. Поэтому, пожалуйста, приходите. И у нас есть еще один вопрос. На фоне приема патогенетической терапии есть ли шанс, что не возникнет необходимость в операции по коррекции сколиоза? И что лучше делать, операцию или принимать лекарства?
Of course, we try to balance the two aspects. What we are now doing in Europe, in US, and most of the Western countries is to try to, if the child needs surgery, to leave a space between L3, L4, when, if there is, you know, the injection, there is the space for the injection. We try to understand if the scoliosis is rapidly progressing or if there could be a delay of the surgery. So for instance, if we can still wait a few months before the surgery so that we can at least start the treatment and to see how the child responds, and then postpone the surgery afterwards. So really, it's not impossible to get the treatment even when there is spinal surgery. Our patients who have got spinal surgery in the past are receiving the treatment now through the guide of the interventional radiology. So there is the possibility to have a CT scan of the spine and to find precisely the way, the site for the administration of the drug, of the intrathecal injection. So there are a few options. Of course, when this is not feasible and possible, there is, for instance, the possibility, at least in a few countries, and in the UK where I'm working now, to provide, for instance, the oral compound risdiplam for compassionate use, meaning that this patient has not the possibility to receive other treatment, so that the doctor can apply for the compassionate use of the medication, of the alternative medication.
Спасибо большое. И у нас последний вопрос. Как быть с сильными контрактурами на ногах и руках? Стоит ли делать операцию?
So this is an important question. It depends on the type of SMA, if this is a child with type 1 or type 2 or type 3, and which is basically the aim, the purpose of the surgery. If we want to maintain some sort of function, for instance, if we think that the child has got the strength to stand, or yeah, to move the help of, for instance, or any other joint, probably surgery could be an option, because the final aim would be to maintain this function, to maintain independence. For instance, if we see that this child has got severe hip contraction or severe knee contraction, which do not allow him or her to stand, but of course this child is strong enough to stand, probably surgery can be discussed, because after the surgery he or she will still be able to stand and to maintain, with all the benefits, of course, of standing and so on. And of course this applies to other joint contractures and surgery. But there is always like a plan afterwards. Rarely it's only for aesthetic, you know, for aesthetic reason. There is always a final purpose of the surgery, to maintain function, essentially, or if the pain is particularly important. For instance, some patients can have severe hip pain. So if we think that with surgery this could be addressed and cured, probably surgery can be discussed.
То есть правильно ли мы понимаем, что профилактически без какой-либо цели нет смысла проводить такие операции?
Yeah, preventive, or when probably stretching is no longer effective for the maintenance of the joint mobility, and the only option has become surgery. So in a preventive, but not only preventive, but also when the surgery is the only option. Possibly, this is why it is important to closely monitor with the physiotherapists or with the doctors the progression of the contractures, because we want to be always before it is too late. We want to avoid the surgery when it is possible, using brace, orthosis, splints, exercise.